Hello.
I think you can start.
Yes, sir. We are going to start.
Let the people join. Start.
Okay, sir. So, good evening to all. We are presenting Journal Club, the Sunset Trial from IPGMER, Kolkata. Title of the study, Prophylactic Surfactant Nebulization for Early Aeration of Preterm Lung. A randomized clinical trial, also Sunset Trial. This trial was published on British Medical Journal, November 24, 2022. And the impact factor for the journal is 96.22 for the year 2021 to 2022. Trial site was delivery room of a tertiary neonatal center in Zurich, Switzerland. Trial was registered. Ethical clearance was taken from human participants and approved by Cantonal Ethics Committee of Zurich. Support regarding support and funding. This trial was supported by European Society of Pediatric Research and also supported by Anna Muller Grossolowski Foundation and also by Filling the Gap grant of the University of Zurich and by EMDO Foundation. Time period of the trial was between March 2021 and January 2022. Background of this study, we all know respiratory distress syndrome is usually treated by a respiratory support and exogenous surfactant application. Surfactant is commonly administered into trachea, either by endotracheal intubation or by a minimally invasive procedure. Both methods require laryngoscopy, which carries the risk of vasovagal reactions and may be associated with intraventricular hemorrhage. Thus, a truly non-invasive approach to surfactant application is still sought. And surfactant nebulization may be a promising alternative. In a meta-analysis of preterm infants with RDS, surfactant nebulization was associated with a reduced need for intubation within 72 hours after birth when compared with standard care. To date, clinical studies on surfactant nebulizations were restricted to infants in the NICU, and this is the first trial done in the delivery room. Even though delivery room management is essential for prevention of long-term lung injury, the effect of early prophylactic surfactant nebulization has never been investigated so far. And electrical impedance tomography allows non-invasive and radiation-free lung volume imaging, thus making it a valuable tool for monitoring preterm infants. Changes in end expiratory lung impedance are a good measure for changes in overall lung aeration in preterm infants, and it will correlate with changes in functional residual capacity. Aims and objective. Aims was to determine whether prophylactic surfactant nebulization improves early lung aeration. Study design. This was masked, parents and health workers were masked, parallel prospective randomized control trial. Inclusion criteria: babies born between 26 to 31 completed weeks gestation and antenatal signed informed consent. Exclusion criteria was severe congenital anomalies, no realistic prospect of survival, genetically defined syndrome, and not willing to participate in this trial. Primary outcome for this trial was the difference in end expiratory lung impedance from birth to 30 minutes after birth. That is delta change in end expiratory lung impedance in 30 minutes, and delta change in end expiratory lung impedance well correlated with functional residual capacity. Secondary outcome for this trial was physiological and clinical outcomes. Different. Sample size. In a previous in a pilot measurements in the same unit, pilot measurements end expiratory lung impedance increased by a mean of 11 arbitrary unit per kg with standard deviation of 11 arbitrary unit per kg over the first 30 minutes after birth. So to detect an additional increase of 11 arbitrary unit per kg in the surfactant nebulization group, corresponding to 1/3 the effectiveness of minimally invasive surfactant administration with a power of 80% and alpha error of 5%, a sample size of 32 infants, that is 16 per group, was required. Randomization and masking. The random allocation sequence was generated by a member of the research team who was subsequently not involved in randomization on patient recruitment. Using the online randomization option in RedCap app, another researchers randomized infants immediately before birth in a 1:1 ratio to either standard care, positive descending pressure alone, or additional surfactant nebulization using random block sizes of 2 and 4. Parents and healthcare providers on the NICU were blinded to the intervention, but due to the nature of the intervention, the clinical team in the delivery room was unblinded. The outcome assessor was also unblinded. Statistical analysis. Normally distributed data are represented as mean and standard deviation or 95% confidence interval. Non-parametric data were presented as median and interquartile range. Differences between surfactant nebulization and standard care were evaluated using a t-test or Wilcoxon test depending on data distribution. Dichotomous outcomes were compared using Fisher's exact test. In case of significant differences, comparisons of secondary outcomes were corrected for multiple testing using Bonferroni-Holmes method. Adjusted p-values less than 0.05 were considered statistically significant, and statistical analysis were performed using R statistics app versions 3.6.2. Intervention. All infants received delayed cord clamping, and once they reached the resuscitator, they were supported on continuous positive airway pressure with positive inspiratory pressure of 8 millimeter using the Avenio ventilator and a face mask. The decision to escalate pressure levels, to initiate NIPPV, or to switch the interface to a nasopharyngeal tube or nasal prongs was at the clinician's discretion. Intervention continued. In the intervention group, 200 mg per kg surfactant, that is poractant alpha, based on the prenatal weight estimate, was nebulized via a customized vibrating membrane nebulizer positioned between the face mask and the ventilator circuit. Nebulization commenced simultaneously with the first application of a positive distending pressure after birth and continued until the entire surfactant was nebulized, irrespective of the mode of non-invasive respiratory support to the infant. This was the interface system. Ventilator circuit, flow sensor in between the nebulization chamber, and face mask, and impedance electrical tomography belt measuring impedance changes, which correlate with the functional residual capacity. So infants were randomized to the control group, had the same setup without the nebulizer, and they received positive distending pressure alone, that is CPAP or NIP. Data collection. A researcher not otherwise involved in the resuscitation was present for each delivery set to set up data collection devices before birth. A textile electrical impedance tomography belt was fastened at nipple level as soon as the infant reached the resuscitator. The Lou Mon device from the makers for Switzerland was used to record electrical impedance tomography data at frame of 51 Hz. Stabilization were video recorded from above, providing a view of the infant's body and operator's hand. Airflow, airway flow, and pressure were measured continuously using a flow sensor with an accuracy of ±5% placed between the T-piece ventilation device and the face mask until the infant was switched to nasal prongs. Heart rate and preductal saturation were recorded using a Massimo radical 7 pulse oximeter. FiO2 was measured using an oxygen analyzer in the inspiratory limb of the ventilator. Respiratory function parameters were recorded at 200 Hz using the New Life Box recording system, and breaths were extracted using the Palmo chart software. So results of this trial, the concept flow chart. First, 205 mothers screened, out of which node approach 63 due to discharge before approach or delivering before approach or genetic syndrome. And out of this, 142 parents approached, and out of which no consent were obtained from 45 due to declination or discharge before follow-up or delivered before follow-up. So 97 parents consented, out of which 67 infants to not randomized delivered after 32 plus 0 weeks gestation, 56, and delivered too quickly to set up research equipment, 1, and no information to research team, 5, and twin of randomization infant, 5. So 35 infants randomized. Allocated to surfactant nebulization was 18, out of which 2 excluded due to technical failure and intubation before primary outcome. And allocated to standard care 17, out of which 1 excluded because of intubation before primary outcome. So 16 in each group were analyzed. Baseline characteristics, there are no baseline differences between groups, but in this chart there is 2 significant findings. Premature preterm rupture of membrane was 38% in the surfactant nebulization group and 19% half in the standard care group. And also the completed antenatal steroid were 81% in the surfactant nebulization group, and the standard care group was only 63%. So these 2 parameters, preterm premature rupture of membrane and completed antenatal steroids, both were protective for RDS in the standard surfactant nebulization group. Primary outcomes, 30 minutes after birth, delta change of end expiratory lung impedance was not significantly higher in the intervention group, median or interquartile range. Delta change in EELI 30 minute 25, 7 to 62 arbitrary unit per kg versus 10, that is 0 to 26 arbitrary unit per kg with a p-value of 0.21. So in this whisker and plot diagram, we can see at 6 and 12 hours of life, there is a change in mean airway pressure in the surfactant nebulization group. Also, these are showing also mean airway pressure and SPO to API2 ratio over the first 24 hours. Safety. Safety, 2 serious adverse events noted in the intervention group. 1 infant developed a pneumothorax requiring drainage 3 hours after birth, and another infant had an airway obstruction with persistent bradycardia during surfactant nebulization, requiring into suctioning and subsequent intubation. Secondary outcomes, delta change in end expiratory lung impedance was slightly higher in the intervention group. 6 and 12 hours of birth, which was mainly attributable to central lung areas. After correction for multiple testing, there were no changes in the ventilation distribution, mean airway pressure, SpO2 and FiO2 ratio, heart rate, as well as detailed respiratory function data between the groups. So these are the lung areas shown. Main change was in the middle zones in the 4 horizontal planes. Regarding secondary outcomes, these are so secondary outcomes. Regarding secondary outcomes, besides an increased number of overall doses of surfactant in the intervention group, there were no significant difference in the clinical secondary outcomes. So discussion, delta change and end expiratory lung impedance are a good correlate of functional residual capacity changes. In this study, delta change in ELI 30 minutes after birth was higher after surfactant nebulization compared with standard care, but this did not reach the statistical significance. The median difference was as large as hypothesized, but the confidence interval were wider than expected, which may be due to the highly adaptive situation in the delivery room with irregular breathing patterns and rapid changes in aeration. With longer expiration times during the transitional period in the delivery room, the deposition rate of surfactant nebulization may be further hampered. Still, functional residual capacity was increased after surfactant nebulization at certain time points, possibly corresponding to reduced alveolar surface tension and consequently to a reduced end expiratory alveolar collapse. Unsurprisingly, this effect was strongest in the central lung areas where the majority of airflow is directed. Compared with the immediate effect of instilled surfactant, the effect of nebulized surfactant on functional residual capacity was delayed, likely due to deferred formation of an active surfactant layer during the gradual lung fluid absorption in the distal airways after birth. However, there are other factors possibly contributing to this finding. Infants receiving endotracheal surfactant were excluded from electrical impedance tomography data analysis, which may have contributed to increasing differences over time. However, inclusion of ventilated infants would have skewed to the data even stronger. There was a non-significantly increased rate of antenatal steroids as mentioned. So there was a non-significantly increased rate of antenatal steroids and preterm premature rupture of membrane in the intervention group, and both factors are known to reduce respiratory distress syndrome. Considering these confounding factors, there may well be no clinically meaningful effect of prophylactic surfactant on lung aeration. So while intratracheal surfactant application improves lung aeration as well as ventilation homogeneity, the study did not show a meaningful effect of prophylactic surfactant nebulization on physiologic outcomes. Any effect towards a different ventilation distribution were marginal and vanished after correction for multiple testing by von Frauenhorn's method. Most importantly, neither ventilation nor aeration homogeneity was improved after surfactant nebulization. The deposition rate during surfactant nebulization, particularly in the delivery room where with longer expression times, may be too small to achieve even a physiological effect. A higher surfactant concentration per milliliter increases the surface activity of pulmonary surfactant and may possibly yield a measurable relevant effect despite low deposition rates. However, detailed bench studies evaluating different interfaces, nebulizers, and concentrations of surfactants are needed before further clinical studies are warranted. Previous studies evaluating the safety and efficacy of surfactant nebulizations were limited to the NICU. So the study demonstrated that surfactant nebulization is feasible in the delivery room also, providing a basis for future trials evaluating clinical outcomes of prophylactic surfactant nebulizations. A recent meta-analysis comparing surfactant nebulization with standard care in preterm infant respiratory distress syndrome revealed a small reduction in intubation rate after surfactant nebulization, particularly in infants more than 28 weeks gestation. So in the trial, the intubation rate was slightly higher after surfactant nebulization, but the current study was not powered to detect the clinical differences. Though in the Goldsmith textbook in the exogenous surfactant therapy chapter, one study they have mentioned that surfactant nebulization in the NICU reduced the intubation rate from 50% to 25% with a number needed to treatment was 5 in one study they have quoted. Considering that the study did not see a physiological impact of prophylactic surfactant nebulization in this small trial, clinical effect seems unlikely. Thus, further bench studies are needed to re-evaluate the ideal combination of device, surfactant concentration, and interface used for prophylactic surfactant nebulization before further clinical studies warranted. So limitations of this study was, the study has various limitations. First, it was a single center study and results may not be generalizable to different units with the differing approaches to neonatal stabilization. Secondly, a small sample of 32 infants, which limits the clinical validity of the data and was not powered enough to detect clinically meaningful differences. Third, only included infants between 26 to 32 weeks gestation, while the necessity of preventing respiratory failure is largest among infants less than 26 weeks. In this, a limited age range to show the feasibility of performing surfactant nebulization in the delivery room despite the rapidly adapting situation. Fourth, the study only investigated a specific combination of nebulizer, dose, and concentration of surfactant. Although they mentioned if concentration of surfactant increases per milligram, it increases the efficacy. Fifth, the neonatal team in the delivery room and the outcome assessor were unblinded, which introduces potential biases. Limitations of the study continued. Finally, infants were initially stabilized using a face mask. There is less lung deposition of face mask compared with the interfaces positioned closer to the glottis. While face masks are still widely accepted as primary interface in the delivery room, the ideal interface for surfactant nebulizations and still needs evaluated.